At the onset, I'll thank the organizers for inviting me to give this talk, and this is based upon a abstract published in ASCO, and it is about patients' preference for adjuvant osimertinib in NSCLC. So there are clinical controversies surrounding the US FDA approval of osimertinib in December 2020 in adjuvant therapy based on a DFS improvement in patients with surgically resected stage 1B and 3A EGFR mutant NSCLC. Hypothesis for this was whether the DFS benefit alone, even without significant OS benefit, may be deemed a valuable endpoint for patients after considering the trade-off. The type of this study was survey of the patient. It was a multicentric study, and the participants were recruited from patients seen at the Roswell Park Thoracic Clinic. Duration was from January 2021 to December 2021. Eligible patients who were evaluated for adjuvant systemic therapy following surgical resection were given a self-administered survey based on the validated questionnaire by Blinman et al., which was modified to provide explanation of the difference between OS and DFS and the ADAURA trial results. Survey responses from the patients were collected in an online repository. The statistics used here was for association between survey responses and demographics were assessed using Fisher's exact test, and changes in preference responses were assessed using McNamara test. Coming to the results, 524 patients with NSCLC were screened, out of which 101 patients were eligible to receive the survey, out of which 50% responded to the survey. Median age of the respondent was 69 years. Majority were female patients, had marital status, was married. Most of them were retired, and at least some college or higher education level degree was there with them. Most of them had history of smoking, and predominantly stage A patients and adenocarcinoma patient had responded. What they had shown that to evaluate toxicity trade-off, which was in question 1, a more than 12 months improvement in OS benefit was needed for 66% of the patient to consider adjuvant osimertinib. However, an increase in more than 6 months of DFS was enough for 66% of patients to justify taking a daily medication. A 1 month increase in DFS or OS was not enough for 60 to 78% of patients, respectively, to justify taking the medication. A threshold of 1% increase in 5-year OS was sufficient to persuade patient to take osimertinib for 3 years, even with the respect to toxicity side effects. Finally, in the hypothetical cost-based scenario, there was no indication that patients were willing to pay more for each incremental increase in OS. And there also appears to be some degree of association between the employment status and educational degree for tolerance of side effects if there is at least 1 year additional benefit in either DFS or OS. So the conclusion which was drawn from this study was, it was observed that the value patient ascribes to adjuvant osimertinib is influenced by factors besides efficiency. Knowing patients' preference for cancer treatment can better inform regulatory bodies in formulating cost-sharing structure for cancer therapies. This study highlights the importance of shared decision making based on individual patient preferences. It was non-sponsored. Research sponsor was not there. Thank you.